Welcome to the Tier 1 Health and Wellness Podcast, the home of evidence-based medicine, and it is my extreme excitement. I have to say, I'm actually excited to have Dr. Andrew Winge on our podcast today. I'm a huge fan of Dr. Winge. I've been following him for quite a while, and I'm absolutely impressed every time I see him put out a new video or any information. He follows evidence-based medicine to the core. I've never been as impressed with any individual I've seen out there in the recent year or two that I have Dr. Winge. So it is my extreme pleasure. He is the CEO of Man Medicine. It's a telemedicine only practice for men where he runs the Man Medicine Academy. First and foremost, I want you to tell us about yourself and what brought you to the field, and also your own personal experience of what you may have gone through. But also, I want to thank you first and foremost for serving our country. I cannot tell you how much
Thank you.
that means to me and everyone else. So thank you very much.
Thank you, Keith. Yeah, it's a huge honor for me to be on your show. I know you don't know this, but I've followed your content online for quite some time, and I've learned a lot from you from a distance. So it's a huge pleasure. When that invitation came through in my email, I was very excited about it too. So really appreciate you having me on here. But I got into this space through my own issues. I think a lot of us as physicians that were in traditional medical specialties and then eventually transitioned into men's health, bioidentical hormone replacement, many of us entered into this space because of some of our own personal issues. My medical background, just for the listeners, is I'm a traditionally trained MD. I went to the Uniformed Services University, which is I was military trained from day one. I did a full career in the Air Force. I'm board certified in family medicine and emergency medicine, deployed on a number of occasions, and I still practice full-time emergency medicine as well. So I see the entire spectrum of the healthcare world, or I have at least in my career, and I continue to practice in that broken system. So, but as far as how I got into this, in my mid 30s, like a lot of men, I think I felt that something wasn't quite right. And for a long time, it started in my second residency, my emergency medicine residency. And I attributed that to, listen, we're working 80 to 100 hours a week. Emergency medicine is shift work. So the circadian rhythm is just a mess for all of us. But when I got out of training and things got a little bit better from a lifestyle standpoint, and I was still working a lot, still very busy deploying, and had Air Force duties and things like that. But things were not getting better. I was primarily just very fatigue is a big one that men complain about, and I realize it's kind of a nebulous complaint, but I was not as sharp as I was on my shifts. I was having difficulty remembering drugs and dosages, and I found that the nurses were catching little mistakes that I was making. And in a level 1 trauma center, which is where I was working, you can't afford to have those kind of mistakes.
That's right.
And so I noticed things were slipping. My libido was certainly in the toilet. It was affecting my relationship at the time. As a physician, you would think that I would have put 2 and 2 together, and said, listen, I need to get this checked out. But I didn't. I should have known better, but I didn't. But I had a colleague who was a urologist who said, listen, let me order a testosterone level for you. Yeah, and lo and behold, it was in the just right above 300.
Mm-hmm.
And for me, obviously, that was low enough to be highly symptomatic. And the background to that, also an additional data point. I was born, I had bilateral cryptorchidism, which for the listeners is undescended testicles. And I was not born in the United States. I was born in Spain. And it either was missed when I was born, or they just didn't really understand how important it was to correct that surgically, which we do now. And typically, like when a baby's born with that condition, usually within about 6 months, they want to bring the testicles down out of the pelvis, into the scrotum to prevent damage. Well, mine were not repaired till I was like 3.5. So I always knew that I would have fertility issues, but everyone, that I had seen as a kid and even as a young adult said, you won't have any issues with testosterone with that. That was what we thought at the time. Well, lo and behold, we know that that's not true. That's not true. So I presumably had pretty good testosterone levels as a teenager. I survived puberty. I was a competitive powerlifter in my early 20s and completely natural, and was able to put up some decent lifts, put on a lot of muscle. So I'm assuming I had natural testosterone levels as a young man. But something happened in my mid 30s, and I know men, a lot of men have that story. And so, long story short, I got on testosterone replacement, and I'm the kind of guy that if I'm going to delve into something like this for myself, I have to know everything about it. So I went down the rabbit hole. I took as many CME courses as I could. I got as much training as I possibly could, and I continue to do it because I learn new stuff every day in this field because it's I just find it so fascinating. But it radically changed my life. I got the old me back, so to speak, and it may have been placebo. I'm fully willing to recognize that, but gosh, within 7 to 10 days, I just felt like that fog had lifted, and the clarity and the sharpness that I had intellectually was back. I was able to work more emergency room shifts. At my workload, I could handle it now.
Right.
And I just, I not to make light of it, but I was, men with low T they get kind of bitchy and irritable, and they don't handle adversity very well. And
Right.
that's not me, but that was definitely happening to me. And I noticed that corrected very quickly. Things that bothered me previously didn't bother me. I became, a much better partner in my relationship. Now, fast forward years later, I'm a much better father than I know I would have been. And I credit testosterone with all of that. So when I saw those, when I saw what it did for me and I learned more about it, I recognized what a huge problem this is. And of course, it's only gotten worse, in the 15 years since I started treatment. I wanted to help other men, have those kind of same experiences. Because once I started asking, and once people kind of knew, they heard me talk about testosterone, they just came out of the woodwork. And I
Right.
said, well, I feel exactly the same way. And I would I started with some friends and family, of course,
Right.
and lo and behold, I was getting very similar, if not worse, numbers than these guys. And then, I was still on active duty at the time, and I was shocked by some of the low numbers that some of our deployed soldiers were coming back with. And many of those guys had traumatic brain injuries and were being put on antidepressants and some of these
That's right.
atypical antipsychotics. I know you've seen this 100 times, and I know you've talked about it too, but many of those guys were suffering unnecessarily, I found, and simply because nobody had ever thought to check a testosterone level, let alone a growth hormone, IGF-1 level, thyroid, let alone any of that other stuff. They were
Right.
all being put on antipsychotics, antidepressants, and many times that was just making things worse. Fast forward to now, this is a huge part of my life. I'm still in the emergency room, and I'm still taking care of, critically ill and injured people. Emergency medicine is a young man's sport, I say, and I'm not getting any younger. So I, eventually will be transitioning full time into this because it's just so enjoyable. I feel honestly, people who don't know medicine maybe can't appreciate this, but I save more lives in my hormone practice than I do in the emergency department. I think I've made a bigger dent in the universe in terms of helping people by practicing this kind of medicine that I have in the emergency room outside of my military deployments. Of course, that's a different story.
Well, there'll be a
So
lot of
that's kind of the origin story. I mean, that's in a nutshell how I got into this. Many of my own issues were solved by testosterone. So I'm a huge advocate. And of course, once you learn about testosterone, then you start learning about the other hormones. I love what you have said in the past about the fact that we need to address all the hormones. We need to bring them all up to healthy, optimal levels and not just focus on testosterone or thyroid or, we need to look at things from a holistic standpoint, and as a family med doc, that's music to my ears, looking at the big picture. So I'm a big advocate of all of those things. All the things that you've talked about on this podcast are right in line with how I practice as well.
Well, your history absolutely mirrors my own. It's amazing
Yeah.
to hear that
Yeah.
story because that's
Yeah.
exactly what I went through. I tell my patients all the time, the reason I do what I do today is because I was mismanaged, misdiagnosed, and
Yep.
mistreated by my own colleagues, and it
Hmm.
wasn't purposely. They just didn't know
No,
any better.
no.
And I also was trying to juggle two practices, a spine and sports
Hmm.
practice along with
Hmm.
hormones, but it just got so busy, but also so satisfying that I
Hmm.
ultimately had to give up one because I just couldn't manage
Yeah.
them both anymore. And so several years back, I, went full time into the hormone field, and it's been a godsend since then because
Hmm.
I think people out there, they don't really understand that from a clinician standpoint, what you do
Hmm.
and what you get to do every day and what you've just outlined is what I get to see every day as well. You may
Hmm.
think that what we do, we get to deal with problems all day long, like we did in the ER, or like you do in the
Right.
ER, or like I did in spine and sports.
Yeah.
But look, what we get to deal with, different from what you may think, because what you see and read on forums is we get to deal with success every day. It's very rare
Absolutely.
that we run into any problems with what we do. And it's just amazing that you just get to talk to man after man after man every day and talking about how much better they are.
Right.
Much different than people may think. They may think that, once again, that we are having to put out fires all day long or deal with,
Hmm.
the issues that you've had done podcasts on, for everything from gynecomastia, this, that, and the other. Well, we
Hmm.
don't. We
No.
literally do not have to deal with
No.
those issues. They're very rare. So,
There's a lot of talk about physicians burning out in medicine, and I understand that. I've been burned out on more than one occasion in my career, but I think a lot of that burnout comes from this feeling like we all went into medicine to help
mhm,
people. And if you're practicing in the mainstream medical world, whether it's in the emergency department, ICU, even in a regular primary care practice, many times I felt at the end of the day like I hadn't really helped anybody.
mhm,
I was not making the world a better place. And I know, again, that may seem kind of strange to people who are not in the medical system, but um, that's not the case with this type of medicine. It's
right.
the radical changes when you have a patient buy into the things that you're telling them, and they trust you, and of course they're willing to put in the work. I 100% agree with Dave Lee. That was a great podcast that you had. I love how he talks about getting the results that you deserve. So when you have the right patient and the right uh, treatment plan, the transformations are just radical.
They certainly are.
And there's nothing better, like, as a physician, than you feel really. I feel good about that. Um, and
Yeah.
I don't feel as good at the end of the day in the emergency room when I put a Band-Aid on somebody's chronic problem, or I send them to the OR to get their foot amputated. And I don't feel good about that. But if I get a guy and I can get his hemoglobin A1C from 10 to 6.5 with testosterone, thyroid, and some nutrition and training advice, I feel great about that.
Right, right. Well, it is rewarding. People need to understand that we're human too. We have feelings too, and
Yeah. Yeah.
our
Yeah.
self worth is defined by our success rate, and
Mhm.
it would be it's it's terrible for those physicians that deal with disorders that never get better, like neurologists, for instance.
Oh, I know.
And so
Exactly.
it's very depressing. But you're right.
Yeah.
It's just a six. And as you mentioned about the Dave podcast and everything, if a guy will put in the sweat equity,
Mhm.
the results can be amazing and work.
Amazing.
Testosterone, real reward effort. I mean, what's the saying? Don't be upset by the results you didn't get by the work you didn't do.
Right.
Well, if you'll put in the
Exactly.
work, you will
Yeah.
literally you will be successful, but it does
Mhm.
require quite a bit of sweat
Mhm.
equity,
It does. Oh,
that's
100%.
the key. That is the key.
Yeah, testosterone won't, it is not a panacea. And I know we were going to talk about that, but that's again, that gets back to what we talked about at the beginning here before we started recording about expectation management, and men need to really understand that this is a partnership with the hormone. And you will get out of the hormone what you also bring to the table, what you put into it. And if you don't bring anything to the table, and you're not willing to make even these more basic changes, then you get what you get. So
Right. And the men that don't see results, I know you've had them too, and I've had
sure.
them. You get great levels of hormones
Hmm.
across the board, just really couldn't be any better. But then they're still gaining weight and still having these issues. And you'll ask them, well, you really need to, let's evaluate the diet and exercise rate. Nope, I got a perfect diet, I
Right.
exercise. Well,
Do you
the
really?
men that are most successful
Yeah.
are going to be able to sit back and take a critical analysis
Hmm.
of their life. They're really they have
Yeah.
to. For instance, I work out hard. Because you go to the gym for an hour doesn't mean you're working out hard. Doesn't mean
Oh
you're doing
no.
what you need to do to literally
Right.
lose weight, especially body fat, gain weight. That doesn't mean anything walking into the
No.
gym. And
No.
because you're a black belt in
Yeah.
jujitsu, which is
Hmm.
awesome, by the way. I worked with all the
Thanks.
MMA fighters. I was one of the
Hmm.
ringside physicians for
Hmm.
the UFC, and those are some hardworking guys. And
Yeah.
when people want to talk about working hard, look, whenever they say they work hard, you can always work harder, because when those
Oh
guys
my
are
gosh.
training for a fight,
Absolutely.
and when you're out there training for a competition, that's hard. Now there's
Better
just a
believe it.
different level. You can take it up a notch, and
Hmm.
so
Hmm.
that's the key. Is these guys,
Yeah.
you can't really. I hate to use the word, you want to argue with them, but you do try to kind of help educate them. But some
Hmm.
are mendable to change, and some are not.
Hmm.
So there's a difference
Absolutely.
between
Yeah.
exercise and
Absolutely.
training. I mean, when you're training, Yeah, you're working toward an
Well,
end.
yeah, there are levels of training,
Yes,
as we
there are.
know, for sure. And that could be a little daunting. I mean, I get guys like I'm sure just like you do who have made it into their late 40s and have never exercised. Those guys, we start with, if you're 450 pounds, we start with a walk around the block.
That's right.
That's where we start, right?
Right.
But my goal is eventually to get you to the highest level of intensity that you're willing to tolerate and do that. So you have to meet people where they are, obviously. But again, it's funny, the harder you work, the better the results. There's no question.
So, Andrew, you're obviously on testosterone. You're in excellent health. We all know that. You're a black belt in jujitsu. So let me ask you this. Do you have an erection every morning?
No, no, I
Yeah,
don't.
yeah,
No,
me neither. Do you feel like working out every day?
no, not a,
Do you
not,
get it when you
no,
do work out? Are they always good workouts?
no. I never regret a workout, but they're not always
Right,
stellar
right,
workouts, not even
right.
close.
Does your libido, is it just 10 out of 10 every day of every
No,
week? Just feel
no.
like that? Okay. All right. Interesting. So, do you get tired many days in the afternoon?
Keith, I do get tired. Yeah,
Right, right. Me,
it's
me, me
strange.
too. Well, Andrew,
Yeah,
do you realize you are absolutely not dialed in?
right.
Obviously.
Well, that's my
So,
protocol.
so when people want to use these dialed in, then you should be adjusting your protocol, Andrew, because neither one of us are dialed in, despite probably having
Right.
as optimal levels of hormones as you could have.
Exactly.
So men out there, that's not what dialed in means. When we're
Exactly.
treating men with a testosterone deficiency, we're treating men with symptoms of low testosterone. I made this comment to Andrew. I've never made it on a forum before, online before, but I'm going to make it now. Everyone benefits from testosterone, male, female, young, old, but not everybody needs it. And so that almost sounds like, what do you mean, Dr. Nichols? If everybody benefits from it, why wouldn't everybody need it? Well, because I can't squeeze out the performance enhancement characteristics of testosterone. The benefits when you take it in everyone are going to be increasing lean muscle mass, strength, endurance, exercise tolerance, bone mineral densities, healing capacity, recovery time. That's why it's banned in sports. That's why young men pro athlete can't take it. But that doesn't mean everyone needs it. The need comes from a person experiencing symptoms of a deficiency for that
Hmm.
individual. They
Hmm.
have symptoms of a true testosterone deficiency. And when we give those men testosterone, we overcome those symptoms of deficiency and therefore make them a normal human subject to all the ups and downs that all of us normal humans have. It does not make us we do not live in a perpetual state of nirvana every day. And people can't use hormones like a stereo equalizer, as I say,
Right.
when they're having a bad week or a bad month. They just can't make these adjustments and think that they're going to overcome life with hormones. We overcome your symptoms of a deficiency. As long as you continue to do what you're doing, you will continue to resolve your symptoms of a deficiency. But you're going to have good and bad days, good and bad weeks.
Yeah.
You're not going to have a raging libido all the time. And I'm sure you see it all the time. Doc, I don't have the libido I think I should.
All the time.
All the time. That
All the
one of the
time.
common complaints is, well, I can't give you the libido you think you should have. Your levels are optimal, and there's about 14 other factors that go into libido. We all want certain things. That doesn't mean we're going to get it. I mean, I
Right.
hate, life is not always fun. It's not always,
Exactly.
but what we're certainly, the bigger picture is that we're using these hormones to overcome deficiency to maximize health.
Exactly.
So that's
Exactly.
really my,
Exactly
my
right.
take on expectations, and so please enlighten us on some of the things that you see and what you run into when it comes to men and their expectations.
That was beautiful. That was far more eloquent than I could ever explain it. It's absolutely right. Now, when a man comes to me and to any doctor, they're typically coming in with a set of complaints, so signs and symptoms that are bothersome to them. And so it's up to us, as good clinicians, to take a good history, do a good physical exam, and then come up with a treatment plan to try to address those. Now, obviously, I do that, you do that, we all good clinicians do that. I also have some things as a medical doctor, goals for them that perhaps they maybe are not their top priority. Things like, I really want your cardiovascular risk factors to be as optimal as possible. I'd like you to have good blood pressure. I'd like your lipids to be under control, your fasting glucose, all these sort of metabolic long-term health parameters. Those are many that's what I'm thinking about.
Dude,
Because in addition to, I would
that's right.
certainly like to help you with your libido, your mood, your energy, your brain fog, your body composition, etc. So I have my own little agenda that's in the background there that I work into my relationship with the patient. But you're absolutely right. And these misconceptions that guys have, I think they come, social media is obviously a big part of that. Social media is it's a double-edged sword, obviously. I was just chuckling last night. I was just trolling through one of the forums before I went to bed, and there was at least 2 posts in there about guys that all of them had been on TRT less than 4 weeks, and they were complaining that they weren't getting, I don't feel any different. What should I do? And thankfully most people on there were like, listen, buddy, you got to give this 4 weeks is not enough time to make a protocol change. But they were already looking.
Sure.
And I blame, obviously, social media and
Correct.
things like that are partially responsible for that. But also it's their clinician. They really, it's obvious that somebody, their doctor, prescribing provider, whoever the case is, didn't sit down with them and do some expectation management with them before prescribing to them. And that's really key to kind of set the stage for expectations. Erectile, many guys come in with erectile dysfunction, and they're under the mistaken belief that the only reason I have ED is because I have low testosterone. And so a week later, after my first shot, when my levels are normal, I should no longer have ED.
Correct.
Well, the data is very clear on that sustained improvements in erectile function can take months. It can take
52
months.
52 weeks, up to 52
Yeah,
weeks.
exactly. And if you have atherosclerosis in your pudendal and penile arteries, I'm sorry, but now we have a mechanical flow issue that we need to address. That testosterone will only partially address that. So that's really important. And you and I both spend a lot of time, I think, managing expectations in guys, because many times they're unrealistic. And I know you've talked about this. I see this all the time. Guys will have a fantastic result out of the gate. 6 months, a year later, this stuff isn't working anymore. And obviously you peel that onion a little bit, and you realize it's not that it's not working anymore. It's your relationship is now, you're going through a divorce, your relationship's in the toilet. You had some other really major life setback, you're not sleeping, etc.
It's always that 100% of the time. Hormones do not stop working.
They're always there.
People will, but they don't. Okay. And that's also true. I'm so glad you see it. I'm so glad you brought that back up, because they just don't stop working. That's not how it works.
They don't stop working. I'm 13 plus years into this. I have an 18-month-old. I got up 3 times last night for that kid. And I'm tired. I'm probably a little less tired than I would be if I was still hypogonadal. I think I handle it better.
Of course.
But when it's 3 a.m.,
that's a baseline fatigue, being hypogonadal. That's a baseline fatigue. And then, of course, but so you don't have the baseline fatigue.
I don't have the baseline.
Tired like a normal person would get. That's not hypogonadal. Everything you've explained, absolutely.
But when it's 3 a.m. in the emergency room, and I've got 4 ambulances deep in the bay, I'm tired, and there's not enough testosterone in the world to fix that.
Or thyroid, not enough of
it. Or thyroid. It doesn't matter. So that's just super important for guys to understand.
It is.
And also, getting on TRT, for example, at age 50 isn't going to undo 30 years of bad lifestyle choices. The damage is done to a certain extent. And so it may take a long time to reverse all of those things that you've done to yourself. It's not like if you quit smoking tomorrow, your risk of lung cancer goes down to 0. It takes many, many years, over 5 years plus to do that. So that's a very important conversation to have with men. And it's, if it doesn't happen, you end up with unhappy patients sometimes. Or they will leave you to go to another practice that, promises them better results. But the reality is they're not going to get better results with them either.
I'm so glad you brought that up. But look, I've said it before and I'll say it again. There are symptoms we want hormones to improve, and there are symptoms that they are going to improve, and they're not always the same.
Absolutely.
But because we want it to improve doesn't mean that it is. And once we raise those levels, to give you optimal levels, give it time to work. Whatever improves, was related to testosterone. Whatever does not, then you need to look at other means. Because it's not hormone related. And so that's really a key part of that. I probably get a little overboard right now with new patients about explaining what it doesn't do versus just about what it does do. Try to temper down those unrealistic expectations, because that can be a roadblock to
Hmm.
efficient care and
Hmm.
good clinical outcomes. So we've got to be realistic in what we're doing. So Andrea, you work in the ER, you're still a full-time
Hmm.
ER doc, which is admirable, of course. And I'm sure you see many people that come in, whether it be on a weekly, monthly
Hmm.
basis, that have maybe overdosed on certain drugs, and not just
Hmm.
illicit drugs. We're talking about literally over-the-counter drugs or medications.
Every day.
Literally tens of thousands of people die every year from drugs like acetaminophen, Tylenol,
Hmm.
and anti-inflammatory drugs like
Hmm.
ibuprofen and Advil. But yet, I don't know of anyone that died in the medical literature from testosterone itself. So we'll see all our patients come in, you and me both, on multiple medications that have all these potential side effects and can cause potential harm. But yet there's this so-called hormonophobia with hormones like testosterone. So would you
Yeah.
like to kind of elaborate on what you see in that regard?
Oh, absolutely. I'm so glad you brought that up. It's a very specific kind of hormonophobia related to testosterone and steroid hormones. And I'm going to obviously lump estradiol in there too. The misinformation about female HRT is probably even
Yes,
worse than it is for men.
of course.
But you're absolutely right. In 24 years, I've never had a single emergency room visit related to testosterone, with one exception. I had an elderly guy who developed necrotizing fasciitis from a dirty injection. He had every risk factor in the book, and he did not use sterile technique. That wasn't the testosterone that caused his problem, right?
Correct.
So, but I mean, just 2 nights ago, I put a guy on a helicopter dying of a GI bleed that was multifactorial, but it was also it was related to NSAID
All
use. So,
right.
yet most physicians, I don't think, bat an eye about
Correct.
prescribing these drugs, prescribing dangerous opiates, that sort of thing. And in the hormone realm, like I said, it's focused, much of the phobia is in these steroid hormones, but insulin is a hormone,
Right.
and doctors don't bat an eye at prescribing huge amounts of insulin.
Right.
And if I had to pick one hormone where I see the most misadventures with, and ER visits, all the way up to including seizure, coma, and death, it's insulin. Yet it is liberally prescribed by physicians in most primary care specialties, endocrinologists, et cetera. The psychology of me is a little bit interesting because we all know about the Endocrine Society guidelines. They tell you have to target a specific number in the normal range. But those very same endocrinologists, Keith, if you came in to the emergency department hyperglycemic, if polyuria, polydipsia, was just thirsty and urinating excessively, would you want me as your doctor to titrate your insulin levels to the high normal to keep you within the normal range? No, you want me to, I'm going to give you the amount of insulin that you need to correct your signs and symptoms of hyperglycemia and reduce the risk of hyperglycemic complications. And I
That's
don't
right.
care what your insulin level is.
That's
I
correct.
might need to give you 100. I've given over 100 units of IV insulin on many, many occasions, which is way super physiologic. But I
Right.
do that because I'm looking for a clinical effect. And most, 99% of physicians don't have an issue with that. They understand that concept. But with testosterone, for example, or thyroid hormone, all of a sudden, if you're over 700, whoa, we need to drop your dose, my friend. I realize you're still symptomatic, but we have to keep you at 700 or whatever arbitrary number they decide. So it's very interesting to me that it's certain hormones we can give wildly excessive doses, or not excessive, but they're appropriate doses for the clinical effect. Yet others, which are actually far safer and have a much better risk profile, are treated like kryptonite.
Right.
They're dangerous, and it just doesn't make sense. It
Right.
doesn't make sense to me at all.
It doesn't make sense because it shouldn't make sense. And to all our listeners out there, what Dr. Winge is explaining is he's explaining that in the ER with insulin things and drugs like that, we are given a pharmacologic dose for a physiologic effect
Exactly.
versus the way we're trained in hormones. They want to give you a physiologic dose. What does that mean? That means they want to keep your levels in a so-called normal physiologic range, or a very specific number in that physiologic range, such as 450 of the American Urology Association, for instance, or mid to upper normal range for the American Urology, I mean the Endocrine Society. So what we're talking about is pharmacologic dosing with testosterone or thyroid for a physiologic aspect, a clinical outcome,
Mhm. Yeah.
improvement in clinical symptoms, not giving us everyone a physiologic dose to
Mhm.
which doesn't work in most instances.
No.
So that kind of and so I'll say this one last thing about that is that look, the fear that they have of testosterone being outside that normal range. And we're not talking about bodybuilders levels. We're talking about optimal levels like you and I see in our practice. There is no harm in that, only benefit.
No.
Every parameter of health that we can measure improves in those men. So the ones that want to keep it in the physiologic range are afraid of they have a fear of
Mhm.
something that doesn't truly exist. I used to say this all the time. It's a boogeyman that does not exist.
Correct.
Okay.
Absolutely.
It's a boogeyman that doesn't exist. So that leads us into
Mhm.
the fact that so when you're treating men there, Andrew, so we know that we're trying to get optimal levels, which we're not following numbers. We are following numbers, but we're not aiming for a number. We're treating
Mhm.
for symptomatic improvement. So
Exactly.
when you're treating those men, I know we'll talk about your methods of delivery,
Mhm.
preferred method of delivery, and how you go about that. But so what are those levels that you typically see? So I'm not going to ask like we usually get asked, what numbers are you looking for? I know you're not looking for one, but in
Yeah.
your practice, what are the typical levels that you see in
Yeah.
a bell-shaped curve where most men get symptomatic improvement?
Yeah, you and I think are pretty much on the same page with that. I have outliers, of course, where they get complete symptom resolution with numbers that are within sometimes even the mid normal range. But again,
Correct.
those guys are outliers.
Correct.
Typically, it is these guys are super physiologic, especially when in terms of their free testosterone, 20, 30, 35. If a man is getting above that level, 35, 40, and I'm really not making a dent in whatever symptoms he came to see me for, sometimes it's important to take a step back and just make sure I have the right diagnosis here and that I'm
Mhm.
not missing something else. But what you said earlier was absolutely correct. With every incremental increase in that level, you just see more benefit. And that is supported in the medical literature. You see improvements across the board. I see improvements in blood sugar control. I see improvements in lipids. I see improvements in well-being. I absolutely see improvements in visceral body fat, fatty liver disease, and those you get those improvements with levels that are above the what is considered to be the average or the normal reference range. And many times you won't get those improvements until you reach those upper levels. There are
There's a
outliers,
there's
but
a dose
that's just the way it is.
there's a dose response
There's a
relationship,
dose
which you're
response.
pointing out is related in this study. So what our listeners need to understand, a dose response relationship, meaning the better the dose, the better the levels, the better the response. Now we are both talking. There's a cutoff point for both of us, and I've said it
Yeah.
out before. Like 30 to 60 is fine. Some of my men are lower than that. Some of them might be a little higher, but that's kind of that range that you see the improvement. Once you start getting above that, anything that's not better is just not testosterone because there is a
Right.
plateau to the feel
Right.
good effects of testosterone. There's a point where those receptors are fully saturated, and you're just adding more is just excess and just going to increase lean muscle mass. That's why bodybuilders do it.
Sure.
So certainly that's what we both see, and I'm glad to hear that. Now, that's unfortunately misinterpreted that by men out there that are not on testosterone. So when they hear us use these words, 30, free testosterone 30, there's probably not many men, if any men out there in the United States right now at baseline that's not on testosterone that naturally has a free testosterone of above 30. I've
No.
never seen that man. I really don't know if he exists. But as you've heard me, maybe you've heard me do these podcasts recently about talking about that to get a good clinical response, it typically takes a level outside the normal range because
Mhm.
when we take the end result, testosterone, we're
Mhm.
bypassing all the events that occur in steroidogenesis, and certainly those intermediate hormones have a role in how we feel and function. So when we make it ourselves, we're going to be more sensitive to it. We see that from a clinical standpoint. So when a man's out there that he's in his early 30s, late 20s, and he gets his testosterone levels measured, and there's 600 or 700, for instance, just making up a number, and that free
Mhm.
testosterone, let's just say 18, 19, maybe even 20, everything's really good. Look, you can't look at the numbers for men on testosterone, that 30 to 60, and relate that to a baseline free testosterone
Right.
level. Because as I've also said, but they failed to hear this part of the conversation is that, look, if I could personally make testosterone myself to a level of 7 or 800 or whatever, and I had a free testosterone of 18, 19, I would probably be perfectly fine, wouldn't have any symptoms.
Mhm.
But since I can't, my levels are much lower than that. But if those are my numbers that made me feel better at baseline, then
Mhm.
great. But when I get on testosterone, what I typically see is it takes a level maybe twice what I could produce myself to get the
Mhm.
same result. So
Yes.
instead of having a free of 19, I may need one of 40. So
Hmm.
the take home message here is a lot of men out there are getting on testosterone that don't really need to be on it
Yes.
because they're aiming for these numbers for men on testosterone, and those aren't the numbers are not the same.
That's
All
right.
right. I hope I've explained that in some degree, and maybe you can help me kind of explain that in a little more detail to our listeners about the point that I'm trying to get across is that don't look at that number if you're 28 years old or 25 years old and it's not 30 to 60, think that you
Right.
need testosterone.
It's
You know,
not.
have the symptoms of a deficiency first and foremost.
Precisely. Yeah, that was perfectly said. Getting back to the insulin thing is just another way to think about this too. The reason that we have people with type 2 diabetes that are on super physiologic doses of insulin is because they have insulin resistance. And androgen resistance is a thing.
Sure.
We have these issues with endocrine disrupting compounds. Many
That's
of
right.
them interfere with the androgen receptor. You don't have a nice clean androgen receptor these days. I don't think anybody probably does. And
No.
so it's not difficult to get a physician to understand the concept of insulin resistance and why you need to give big doses of insulin to control somebody's blood sugar or their triglycerides or whatever. But for some reason, it's difficult to get them to understand the exact same concept with a hormone like testosterone,
That's right.
estradiol, thyroid, etc. It fundamentally it's the same thing. This person has resistance to the hormone for whatever reason,
Right.
and so they are going to require more unless they find a way to clean up your receptor and make it more responsive, which is not going to happen anytime soon.
Right.
The answer is that we need to give more of the therapy. You increase the dose of the therapy, and
Well,
and you achieve the result that you want, and the level will be the level.
Well, when you treat a normal man, my 50, 67-year-old man with that, they do so well clinically when we treat with a a
Mhm.
pharmacology dose physiologic effect. But the problem that we both run into, Andrew, and you know it as well as I do, is what everyone sees out there with regard to social media. Right
Yeah,
now, the abuse of
yeah,
androgens, testosterone, anabolic steroids are glorified. It's just the social media
mhm.
platforms now are just full of those. And so that's what our mainstream colleagues see. And that's what they think
Yes,
that every
yeah,
man wants to do. They all think it's going to be about sex and muscle. So when we're treating these men outside the normal physiologic range, it is truly misinterpreted as those guys
yeah,
abusing it for the wrong reasons
yeah.
because unfortunately, so many people are out there abusing it for the wrong reasons.
There's so many of these misconceptions that it originated in the bodybuilding world, even back from the 70s, they've spilled over into the consciousness of medical doctors and other medical providers and the general public too, of course.
Right.
And it's tainted this really valuable therapy. I do feel like things are slowly getting better with these new generations of physicians that are coming out of their training. They're at least not as they may not be pro testosterone, but they're at least somewhat neutral about it. But there's a whole, your generation and mine of medical doctors that we can show them a stack of papers, and I've done this. You put please read these papers, and they either go right in the trash or they're just unwilling
Same.
to change their opinion, perpetuating these misconceptions about heart disease. Prostate cancer of all things is
Mhm.
still, I mean, that's been put to rest for more than a decade, yet you and I still hear it. And it's frustrating. So I think a lot of these old timers just need to retire,
Well, we say it all the time, and people ask, what's the hardest part of your job? The hardest part of my job and Dr. Winge's job is truly dealing with the family doctor, the internist, or the
Oh
endocrinologist.
yeah.
That is truly the hardest part of our job.
Hmm.
The
Hmm.
hardest part of our job. So then it's all true. I literally have told the story before, and I had two very specific. I used to try to provide information to local providers. I stopped doing that a couple of years
Me
ago
too.
because I literally had two women come back in tears
Yeah.
because they took the packet of information on estradiol and testosterone in women and progesterone, took it to their family doctor, and they both literally right in front of them. As soon as they handed it to them, they opened it up, looked at it, and put it in the trash can right in front of them. That is not a made up story. That is a true story. That's what they think of us and what we do. And I tell my
Yeah.
patients all the time, I wish there was not a need for people that do what I do or for what Dr. Winge does. I wish there
Absolutely.
wasn't a need for what we do. I wish it was
Absolutely.
accepted in mainstream. It would make the world a much better place. There's no doubt about that.
Yeah.
Hey guys, that's all for today. But stay tuned. Dr. Nichols and Dr. Winge will be back next week with a part 2 of this great conversation. Find out what Dr. Winge's preferred testosterone delivery method is. Hear the scoop about how one of Dr. Winge's patients, primary care doctors, got super pissed when she learned what Dr. Winge had done with the patient. And there's a whole lot more coming your way in part 2. For now, please remember to subscribe and hit that notification bell so you don't miss out on our upcoming podcasts. Until next time, stay informed and stay healthy.